My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people.
Good evening. Just wait for that screen share to stop there from the Ramsay Health. There we go. Good evening. My name is Tim Williams. I'm one of the coordinators of this webinar series over the last year.
And I'm Yaser Ghani. I'm the other coordinator of the webinar.
Fantastic. And we wanted to welcome you just to this rather spontaneous and unscripted session where we're going to try and go through some of the topics that have been talked about over the last 51 lectures, I think it is now we're up to, and just try and do some kind of Viva practice, Viva examples of what may come up in an exam such as the FRCS Orth, etc. We want to try and make it interactive. So we're going to grill each other, which is pretty much a first, where we're going to put consultant colleagues on the hotspot and try and answer it, but we're going to try and do that. But as before, there's that Q&A icon at the bottom of your screen. So if you open that up and you want to ask questions, in the background is sitting May Labidi, one of our newly appointed consultants who will feed those questions into us when needed. Evening, May, you all right? The other thing is later on in the hour, if you want to, if you use the raise your hand icon, potentially there'd be an opportunity to have a Viva yourself if you're happy to do so or fancy the challenge. So I think, is there anything more to announce? I think we can get on with it, Yaser, can't we?
I just say if you have any questions after each case, we can take them after each cases. If you don't, then we'll just continue from case to case.
Okay, right, Yaser. I think it's best of luck to both of us, but let's see how we go. I'm going to try and share my screen, all right?
Yeah.
There we go. Can you see that coming up?
Yeah, we can.
Great. Okay, so clearly, just as a disclaimer, these are our opinions and we are doing this live, so bear with us. And any concepts to discuss are open to discussion and are not irrefutable. Okay, so let's see how we go. Fine, we're going to try and cover the salient points, the common discussions, and this is aimed at FRCS kind of level. So, you know, we can get into esoterics, but let's try and keep it sensible and where we want it to be. Go on then, you go first.
Okay, Mr. Williams, your time starts now. So this first, this is a 49-year-old gentleman who presented with a closed neurovascular intact injury. Looking at the radiographs, describe them to me, tell me about the injury.
Okay, well, I can see a lateral and AP radiograph that are non-weight bearing. There appears to be a tri-malleolar ankle fracture, which has got subluxation, if not partial dislocation. There is a Weber B style fracture that can be seen on the AP, but it does seem to extend quite a long way proximally on the lateral. There's a Volscian type fracture of the medial malleolus, and then there's this clear posterior malleolus with possibly a little bit of comminution going on in the joint. So I'm a bit worried about this patient.
Okay. So, Mr. Williams, what would your approach be to the management of this patient?
Well, first of all, I would assess and resuscitate as per ATLS guidelines to make sure the patient is safe and secure. But the priority with this injury, given that it's closed and neurovascularly intact, is to get this reduced and stable. really that's the best painkiller, and it then protects the soft tissues, both the skin from any tenting and being under threat, and also the neurovascular bundle. Get them into a back slab to allow for swelling, and try and get them elevated as well, having made a good assessment of the soft tissues and where we are.
Okay, excellent. So you've reduced this, it's in a back slab now, you've assessed the neurovascular status again, and there is no neurovascular deficit. What's your next step here in the management of this patient? What further investigations could you consider?
So this is clearly an unstable situation. So I'm highly thinking about operative management. And I want some more information here. Anytime I see a posterior malleolus fracture, I always tend to get a CT scan because it can often catch you out, and for that more information.
Okay, so we got a CT scan, and this is what? So tell me a bit more about what you see here.
Well, if I start on the right, what I can see is that this is a CT scan taken at the level of the distal tibia, and the obvious findings are of a fracture of the posterior malleolus. It's quite comminuted, two main parts, but possibly an intercalated fragment we can see here. There's a anterior colliculus fracture on the medial malleolus, and some comminution and bits probably related to the AITFL.
Okay.
I can see a rotating 3D image. And again, looking at the back of that, there's predominantly a posteromedial and posterolateral kind of fracture fragments there. Okay, excellent. So are you aware of any classifications that you can use here for your management? We used to use just Weber B or Lager Hansen, but there's a good paper in the last few years by Mason and Malloy that looked specifically at these posterior malleolus fractures, and basically gave you an idea of what might need to be done about it and the severity. And this would be a Mason 2B, because it's an intra-articular and it's in these two parts, but it's actually probably, it's a little bit beyond that because you've got this separate medial and you've got this comminution here, but I probably would say a Mason 2B. Excellent. So that is correct. And you, as you said rightly, there's probably beyond, but that classification will then aid you in your approach management as well. So here, could you tell me what surgical approach would you use for this patient? Okay, so to get at these posterior fragments, I could either try and fix this in the old-fashioned way as a Weber C and ignore those posterior malleolus fracture. But I must admit, with these comminuted bits and these intercalated fragments, I want to get those out of the way in order to try and get this reduced. So I would tend to do a go at this through either a posterolateral or probably for me a posteromedial approach. And basically a posteromedial approach for me would come in just on the medial side of this Achilles here. So I'll be coming in here and looking for my FHL, and then initially moving FHL medially so it protects the neurovascular bundle over here, and get down onto this posterolateral fragment and try and get opened out to get these bits out of the way, and then try and get as anatomical reduction as I can before holding it in place. So I do a posteromedial approach and then potentially move FHL to the other side and go in between FHL, FDL and around the tib post to try and get into here, to get into this kind of posteromedial fragment and try and clear that out and buttress that as well. One of the key things here is watching out for tib post, because it sits often right in this groove here. And if you put a plate or screw directly on the tib post, it can cause problems. But I would do a posteromedial approach to get at that. I prefer it because I know where my neurovascular bundle is and I can handle it and get it out of the way. With a posterolateral, it's a nicer approach, easier, but the sural nerve seems to hate being handled. And you've got quite a high incidence of sural nerve irritability. And I find, especially if I want to try and get to the medial part, this posteromedial approach, I find quite a nice way of doing it. Fantastic. Yeah. So if you use the posteromedial approach, you can then do a separate lateral approach for that fibula, particularly if they are Weber C type of fractures, high fibula.
then otherwise you have to extend your posterolateral quite high and curve that. So that's great. And as you said, the tibialis posterior, so you've got to be careful with that and probably reduce the posteromedial fragment first, and then the posterolateral will key in there. Fantastic. Okay. So now you've done a fixation, which I will show next. And this is what you've done. So you fixed it from the back, you fixed it the side and the lateral side as well. Now we note that there is no syndesmotic screws in that. Would you consider putting syndesmosis screws in these?
I always do. In principle, because I fixed the posterolateral fragment and I've restored the PITFL, I do apologize, and I've got my fibula out to length, I've got it in good rotation, it should be stable. There is the AITFL, which is a lesser ligament, but I fixed the posterolateral to try and avoid the syndesmosis screw, but I would always do a hook test and an internal and external rotation test of the foot interoperatively to assess that further. And any discrepancy, when here there's only a subtle overlap, I will consider x-raying the other ankle to compare how it's sitting.
Sorry, guys, to interrupt you, Tim and Yaser. You can maybe head off to the next case due to the time.
Okay. Fine. So hopefully there we've covered some the basics of how to approach the posterolateral approach, posteromedial approach, but going about this ankle. If you've got any questions you want to answer about the case, do ping them up on the Q&A.
Mr. Williams, well done on this. Okay. No questions on this at all?
Any questions on the principles of ankle fracture? Common things you'll see come up in a Viva would be, I suppose it could go into compartment syndrome, principles of open fractures, principles of fixation we've covered. VTE would try and cover that at a slightly later stage, I suspect. Well, look, Yaser, why don't we get on with the second case? And then if they come up with some Q&A, we can always go back to this, can't we?
All right, yeah.
So it's now my go. All right. Okay, so let's see how, what should we just get out of that? Okay, so a very different scenario now. This is a 27-year-old lady who's come to see you because she's got a bunion that rubs and irritates in all her shoes. What I'd like to do to start with is just describe what you're seeing on the x-rays.
Okay, so these are the AP and lateral weight-bearing radiographs that I can show. The most obvious deformity here is a hallux valgus deformity. It appears to be congruent hallux valgus. There is sesamoid uncoverage, and on lateral view, there is some elevation of the first ray.
Mr. Ghani, what do you mean by, you said it was congruent? What do you mean by that?
So the distal metatarsal, the articulation surface is actually congruent to the base of the phalanx. The DMAA is high as compared to the, yeah, that's it.
Yeah. So that's it. It's that, isn't it?
Yeah. So the distal articular angle is congruent.
So what's the DMAA usually?
So usually it will be around less than 10 degrees, and then congruent will be more.
Okay, and you mentioned about instability of the first ray and the unstable TMT joint. Yeah. In a young person, what can that be associated with?
So particularly in young people, I would assess the Baton score because of the hypermobility or hyperlaxity. So here I can't really appreciate any increased in between the first TMT joint. However, still do a Baton score on that, and if they are scoring, high, that will give me some sort of indication that this might be related to hyperlaxity or hypermobility.
What makes up the Baton score?
So Baton score is made out of different examinations. So I would start them with elbow, hyperextension of the elbow. Both sides will get you a mark each. If they can actually, I'll show you if they can do the thumb and touch it like I can, they will get each side 1. My fingers go beyond the 90. I don't know if you guys can see it, but I get a point on each side for that. Palms flat without bending the knee, touch the floor, and that will give you a mark. And the last 2 will be then hyperextension of the knee. So it'll be the score out of 9.
Okay, so this young lady does have a high beta score, and she's got instability of the first ray, as you say. So what's going to be your management thoughts regarding this 27-year-old young lady?
So I'd take a detailed history, and the salient points here would be, what's her functional history? What has been done so far? Has she tried any management options? Has she got a family history of this? Has she got any other joint problems? Is she diabetic or any peripheral vascular disease or inflammatory arthropathy? Then I would move on to my examination of this patient. Once I've done the Baton score, I'd stand gait analysis and then sit down and further analysis of the foot. So examine the foot, particularly the range of movement of the hallux, any pain around the medial eminence or prominence. Flat foot, so pes planus, that's quite important.
What would you use? How would you assess a flat foot on this X-ray? On the lateral X-ray?
So I would look at the Mary's angle, which is the axis of the, as you are drawing, of the talus going into the longitudinal axis of the first ray. And normally that should be a straight line. In a pes planus, it's apex plantar.
Yeah. Okay. So basically, this poor lady has exhausted conservative treatment, and therefore has come to you really looking for a surgical strategy to try and sort this out. So what would be, in principle, what is your approach to this, and what would be your concerns? As you mentioned, it was congruent.
Yeah. So with any patient, I would discuss the aims of surgery. And for this, the main aims are provide pain relief, correct the deformity, and then I need to refunction the first ray and prevent any transfer metatarsalgia to the other rays. So as you said, she has congruent hallux valgus. My approach here will also depend on the deformity. So either mild, moderate, or severe. And that would be, mild would be between 20 or 30 hallux valgus angle, moderate would be a 30 to 40, or severe would be more than 40. So here, I think it looks probably moderate hallux valgus.
Yeah.
In my hands, I would, my preference here would be to do a scarf or a chevron osteotomy where, scarf is quite good with an Aiken. It's a versatile osteotomy, quite stable. And I can correct using the distal fragment. I can rotate the distal fragment to allow for correction of the DMA, or a chevron where I can do a medial wedge, closing wedge, which will correct the DMA as well.
Yes, you kind of take a wedge of bone out like that, don't you? And then and that then allows the head to be able to rotate down onto here and get try and correct that DMAA, which is all important, isn't it?
Absolutely, and I think it's crucial here to recognize that this is a congruent hallux valgus. Yeah, because there is a subtle, there's a difference in operative management of this.
I think May's appeared in the corner again.
Yes, I did. Well spotted. So it's me again. I have to interrupt you guys. So it's almost time. If you would like to take a question.
Yeah.
Yeah. So we have Donatas. It's a question really about the first case, the ankle fractures. So Donatas asks, does medial malleolus get fixed through the same posteromedial approach?
So with a posteromedial approach, it would be very easy just trying to erase all that. With a posteromedial approach, it'd be very difficult to get to the anteromedial anterior colliculus fragment. So what I would tend to do is a posterolateral, try and keep it really quite close to the Achilles, and then make a separate incision for my medial malleolus fracture in this case, but it's fracture specific and you have to work with what you see on your scan and what is appropriate at the time.
Great, thank you. Thanks, Tim.
Okay.
Would you like to continue or take the third case next?
Is there another question there? Is it relevance?
No, yeah, we just have one coming in. So it's Anthony. He's asking if doing a closing wedge with congruent hallux valgus, do you need to do anything to deal with the shortening of the metatarsal to prevent defunction in the first ray?
It's a good question, but I think you've got to identify how much you can shorten anyway. And by doing a small closing wedge, I don't think it will shorten, you know, if you, let's just.
All right, there we go.
So if you look at it here.
So, yeah, because what you can do is you can angle your cut, can't you? So you go a bit more lengthening with your cut, or if you just translated that, you would over lengthen, but then because you then subsequently close the wedge, it kind of negates it, doesn't it?
That's the beauty of the scarf. So you can, that's why it's so versatile, that you can actually use it to shorten, lengthen, or rotate once you've mastered it. So, you know, I think you just got to preoperatively plan this, and then be careful planning. And, you know, for all my scarves, I would still plan them, see how much shortening is required, even plantar flexion, how much is required. So on the lateral, the first ray appears to me, you know, elevated slightly. So you've got to recognize that and then plantarize it as well.
We move on.
Yeah. Okay.
Yeah.
So Mr. Williams.
Hold on. I've got to prepare myself. Let me just go to there. There we go. Okay, let's get rid of the pen. Okay.
Okay, so this is your next station.
Mm-hmm.
Tell me, what do you see in the photographs? Particularly, first start off with the one which is just on the left.
Okay. So basically what I can see is there is a cavo varus attitude to both feet. The heel is sitting in varus. When you look down the Achilles, there is a let me just call that up. There's varus malalignment to the heel, and there's a high arch foot, and this kind of peekaboo heel appearance of pes cavus. There is also apparent wasting of the muscle belly, predominantly on the right leg versus the left. And yeah, in essence, that's what I can see on that image.
Okay, so you identified, okay, this is cavo varus foot. What do you think might be the underlying causes of a cavo varus foot?
Well, they are various. When it's this bad, you've got to be thinking of either a congenital cause or an acquired neuromuscular cause. And the commonest one being Charcot-Marie-Tooth or HMSN, but obviously considering other things such as polio or spina bifida. The one worry is that there's a slight asymmetry here, because if it was unilateral on its own, that would make me worried about something like tumor. And if you just see a single side that's got cavo varus foot, I would be very worried about something like a tumor in the spine. Okay,
excellent. So now tell me, you can see the photo on the right, in fact, the video that we're going to play for you. So tell me what is happening here.
So this is demonstrating the Coleman block examination technique. This is trying to show that and just find out whether any cavus foot is driven by the forefoot and that the hind foot is flexible or not. The principle of it is that as you take away the ground from underneath the big toe, therefore negating the effect of the big toe driving it, does the hindfoot correct into its valgus alignment? If it does, then you've got a flexible hindfoot. If it doesn't, then you've got a stiff hindfoot and you have to think about doing something about it.
Okay, excellent. So, or you can, forefoot driven or hindfoot driven as well. So you can identify that. Now, so you've done that. How would you assess this foot? What type of clinically assessing this? Take me through that.
So basically, first of all, I would start with a general examination. You want to look at their back, see if there's any signs of a hairy patch or a spina bifida at all. You want to look at their hands for any signs of interosseous wasting in the hands. And then in the foot, again, you can look for signs of clawed toe, and then start to assess the power in it, because you would expect to see an imbalance potentially in the power if there's a neurological acquired cause, the commonest being CMT. So I would look to assess tibialis posterior, expecting it to be strong, peroneus brevis, expecting it to be weak. Peroneus longus is difficult to test, but you can see by the plantar flex first ray in the photograph that is clearly tight. If it's correctable, you can then look for Achilles to see if that's tight, and also tend to examine tibant, which often you find is relatively weak. And it's that imbalance that causes the deformity, usually caused by the fact that with CMT, it's the most distally innervated muscle bellies that get weak first, and the more proximal ones that stay strong, hence the imbalance that we see.
Fantastic. Okay, so that is quite crucial, isn't it? In CMT, the most distally innervated will be weaker. So how would, say you're in clinic, how would this patient present to you?
It does depend a bit on the age and the severity of it, but initially what I would expect to see in the younger population will be instability of the ankle, so incompetence of the lateral ligament complex, possibly some peroneal tendinopathy from that continual driving posture, hard skin and callus formation with pain on the heel and the forefoot, particularly under the big toe because of the pressure points, and the fact that there's a loss of the shock absorption because of the deformity. They can also sometimes present with knee pain because of the posture that comes through, because of the posture that's driven by the foot. And in later years and more subtle deformities, we will sometimes see either fifth metatarsal stress fractures, or we can see hindfoot arthritis and the presentation of pain from that.
Okay, excellent. So how would you manage this patient? He's in your clinic now.
So basically, I want to establish what are his functional problems and functional demands. So a full history and complete my examination. But in essence, I would initially try and see if this can be managed non-operatively. And that would include both physiotherapy, if there's some flexibility there and there's a neurological imbalance, and also then a foot or possibly ankle foot orthotic to try and manage and work with the deformity if it's stiff with an accommodative style, or if it is correctable on common block, potentially a corrective orthotic using a cutout of the first ray underneath that big toe to try and mimic the common block, so to speak.
Okay, great. So you've done the trial of non-op. Actually, he's still struggling. Operative wise, what do you okay, this one. Now tell me what's happened in this radiograph. You can see this, right?
Yeah, I can see it. So basically, this shows the type of things we might do in the surgery as part of the options available to me in pes cavus surgery. So here is a calcaneal osteotomy where we try and shift the heel into valgus to correct that varus deformity and bring it more to neutral, secured with a screw. This screw here, in all likelihood, represents a closing wedge. A closing wedge dorsiflexion osteotomy of the first ray to try and lift that up and get that to be more less of a driver to the pes cavus. And a screw here that's one of the sequelae you asked me about earlier, which is the stress fracture of the fifth metatarsal, is quite a common presentation. What's not shown. what's
Sorry,
not
Tim.
shown on here is if I've done a correction like this, I've always got to pay attention to the tendon transfer to make sure we get balance back from the tendons, because that's the driving force behind it. Otherwise, you see recurrence.
Excellent. Okay. All right.
Great.
And what sort of tendon transfer would you do in this?
It tends to be a tib post tendon transfer, where we would harvest it at its insertion on the navicular, transfer it through the syndesmosis, and try and plant it centrally or even laterally into the dorsum of the foot.
Okay. All right. So we
Brilliant.
won't go into it, but the question may lead you to about principles of tendon transfers as well. And I think that's another sort of a Vivas scenario. But, you know, if people are, then you can talk about your principles of tendon transfer as well. Excellent. All right.
Yeah.
Shall we move on to the next one? Are there any
Well done. Yeah, I think you're ready for the next case. So just skip the question. Yeah.
Any questions?
Well, there is one question. I'm not sure what is Kanishk exactly referring. I asked him, so he's asking, are these being examined as short or long cases? I guess.
Combination of the two. We're trying to really cover what might come up in an exam in both the short case and the long case. It's all very fluctuant at the moment, isn't it? Because of COVID, you're being presented cases in different ways. But you could be, if you're not getting a patient, you could quite possibly using a picture or an X-ray or a clinical image, take a Viva on through there in both stations, really.
Right. Thank you. You can go ahead with the next case. Thanks.
Okay. Okay. Now we have the opposite. All right. So, Mr. Ghani, here are some clinical images of a 25-year-old lady who's come to see you regarding her right foot. Just take me through what your observations are of these clinical pictures.
Okay, so I can see a clinical photograph on the left of the posterior view of the feet. The right foot demonstrates marked heel valgus with too many toe signs. In fact, I can see the whole foot. The lateral view also shows a dropped arch consistent with pes planus.
What if you were able to examine this patient and you were able to do one particular test while they're standing up, what would it be?
So I'll observe them from the back and ask them to do a heel raise, if they can do that or not, and to see if the heel valgus then corrects or not.
Okay, and what does that tell you about the foot?
So that will tell me if this is a flexible or a fixed one, and that would then alter the management.
So in this case right now, she was unable to single heel raise and there was no correction. And even passively, it was uncorrectable. Okay. Therefore, what investigation would you like to get to start with?
So you said she's a young patient, and if she is not correcting, then my concerns will be, is there a deformity like a coalition, probably? And looking at the radiographs here, the AP radiograph shows some tailor head uncoverage. There is no significant abduction of the forefoot. On the lateral radiographs, I can see the break in the Mary's line. So it is apex plantar, the talus axis, yeah, exactly. And the break is at the talar navicular joint. And also potentially, I think there is a C sign here, which may suggest a coalition, a tarsal coalition.
Which one in particular does a C sign suggest?
So the C sign will be the talocalcaneal coalition, and the other coalition is the calcaneonavicular, which is the most common one, which will be the anteater sign.
Okay, and we sometimes see this little dorsal bump, don't we, on the talus associated with these, don't we?
With these, yes, yeah.
Okay, so how would you assess the patient with this in mind?
So I would assess, take a full history, again, salient points, cover everything, significant medical history, and how long this is. Has she had problems with repetitive ankle sprains or problems at sports from a younger age, because I presume that she's had this for a while.
Yeah.
Majority of them are asymptomatic, but in later life they can become symptomatic. I'd also like to see what examination-wise at gait, single heel raise, as I said, assess the passive and active range of movement of the ankle, and particularly the subtalar movements here.
Okay. And she's come to you because she's tried conservative measures. She's had accommodative orthosis. She's had a very sensible regime with a good podiatrist. She's looking to something more definitive, such as a surgical correction. Let's say actually, for the sake of time, with a coalition, we would take it down. But let's leave the coalition alone for a second. So in the standard situation, or the more common situation, we see a flexible flat foot looking like this. If you've got a flexible flat foot that is correctable, what are your surgical options for correcting a flexible flat foot?
So the most common scenario would be most likely to be a tibialis posterior insufficiency then. And the management, so again, non-operative and operative. Operative management here, if it's a flexible one, will be, I would consider a medializing, so after examining her, I would consider a medializing calcaneal osteotomy. If the Achilles tendon, which potentially is tight, maybe a tendo-Achilles lengthening as well. And then debridement of the tibialis posterior tendon and FDL transfer, plus minus a spring ligament repair. And then after that, to see if the first gray requires a plantar flexion osteotomy, which is a cotton osteotomy.
Where do you do your cotton osteotomy?
It will be in the cuneiform, medial cuneiform.
And what type of osteotomy is it?
Sorry, it's a opening.
Okay.
Wedge osteotomy.
Opening wedge osteotomy. Okay.
And if she had, which on these plain x-rays don't look like the forefoot abduction, then one can consider a lateral column lengthening as well to correct that.
Okay. So realistically, there's kind of two schools of thought, aren't there? There's the medial approach you described, which would be the calc osteotomy, and then the medial surgery, FDL tendon transfer, spring ligament reefing reconstruction, and then the medial cuneiform was necessary. And then or the other option of bringing the foot round is the more lateral surgery, which is a very American style, with a lateral column lengthening. I agree, either through the calcaneocuboid joint or as an osteotomy in the actual sinus tarsal, and to bring it round. Okay, good. All right.
Here I am again. So I think we can go ahead with the next case, but before that, we have a question. Nabil is asking, I believe it's for the previous case, the cavus. He says, what about the peroneus longus and brevis? I believe it's for the tendon transfers.
That's a really good question and a really good point. As part of your menu you have available to you, absolutely, suturing together and debriding and combining peroneus longus, peroneus brevis is one of the things we would consider doing for certain. You won't see that on the x-ray, hence I was trying to use the x-ray and show what was on there, but very definitely buddying those two together, or a peroneus longus to brevis transfer can form part of the correction for sure. That's a really good point. Thanks for bringing that out, Nabil.
And I think in real life, Tim, it's quite an a la carte approach to CAVIS. It depends on, on table, what the correction and what soft tissue balancing is required. So, I think you can say, yes, you can use these, but I will choose, how I will choose on table what to do. But of course, you'll be prepared for it.
Yeah. Okay, we move on.
Okay.
Perfect.
So just to raise that, so we talked about fixed and flexible deformities, locations of coalitions, and then assessment of planning options of what we do. We can come back to orthotics later on if the question arises, but and then hopefully we've talked about the options of correcting flexible flat foot. Okay, over to you again, sir.
Okay, Mr. Williams, you're doing really well in this FRCS exam. So this is a 65-year-old gentleman with extremely painful right ankle. Can you describe what you see in these radiographs?
Okay, so these are lateral and AP radiographs. I can't see the words weight bearing, but looking at the board underneath the posture is probably weight bearing x-rays, but I'd want to know that. And the obvious features are of joint space narrowing, in fact, a bone-on-bone joint space narrowing, osteophyte formation, no evidence of cysts, but some subchondral sclerosis. So features of osteoarthritis, and possibly some inflammatory tissue going on in the anterior ankle. Relevant negatives are that there is no significant subtalar arthrosis, though possibly a small cyst going on there. I'd want to know a bit more, but otherwise the rest of the foot looks well preserved. And on the AP, a little bit of varus malalignment, but nothing significant, and some joint space narrowing at the tip of the medial gutter.
Okay. So he comes to your clinic and says, I've got a really painful ankle, Mr. Williams. How would you manage him?
Well, the key is would be a full history, because you want to establish what his functional presentation is, and also then from that, what his functional expectations and what he wants. I want to know his age and any comorbidities, because it helps me decide what is the kind of safest and most pragmatic options for him. Because first of all, I would be looking to see if he can be managed non-operatively, and if his function is good and his expectations are fair, then use of a small ankle brace or lifestyle modification, simple painkillers, maybe all he needs to keep mobile and keep comfortable.
Okay, so you've tried all the non-operative management and this has all failed. Now he's come to your clinic and he said, I want something done surgery. Tell me about your discussion with him and what options do we have here to manage this surgically?
So, management of arthritis can either be joint preserving or joint sacrificing. If we're going to consider joint preserving options, we could again we could consider an ankle arthroscopy and debridement or a cortisone injection, but I must admit we're bare bone on bare bone of a large proportion. So I'm not sure they would be appropriate. So we're therefore looking at joint sacrificing. There, the option really is arthrodesis or arthroplasty, as I don't think here there's a place for any osteotomy or realignment work. Mm-hmm. To decide between those two, first of all, I'd want to know what's going on that subtalar joint. So I think quite fairly ask for an MRI scan and also fully examine the sinus tarsi and subtalar joint for irritability, because that would potentially slur my options, because essentially I would be discussing him about ankle fusion or potentially considering an ankle replacement.
Okay. So how would you decide? Do you know any trials or any evidence what to suggest?
My understanding is that there is a ongoing randomized controlled trial, multi-center, set up relatively recently called the TARVA trial, that is looking at this, the TARVA trial, which is looking at this very question. We've yet to see published any 2 or 5 year results yet, because we don't truly know the answer. If they've got subtalar arthrosis, that becomes an indication towards ankle arthroplasty, because we want to preserve motion. If we know we've got arthritis elsewhere and stiffness in the hindfoot, preserving motion is very important. But if the demand is appropriate, as in if they were younger and the subtalar joint is okay, then an ankle fusion here is also proven in the gold standard to work very well.
Okay, any other sort of advantages of ankle fusion or replacement?
So, ankle replacement basically does mean your patient can rehabilitate faster. So they're often at 2 weeks, they're getting back on with things and rehabilitating. Although with arthroscopic ankle fusion techniques, you're putting a patient often in a boot by 2 weeks, so they're out and functioning again in a boot. Mm-hmm. The ankle arthroplasty, you're obviously looking at preservation of motion.
Okay.
And at least with an ankle fusion, that is the one final operation.
All right. So what would you do in this scenario? What would you offer him?
May I just remind me of how old this gentleman or person
He's
was?
65, fairly fit and well.
Okay, so he's active and he's 65
Exactly.
and he's got good preservation of the other joints. I would
Yeah.
stick with the gold standard and undertake an ankle fusion.
Okay, fantastic. All right, well done. And lastly, what position would you fuse his ankle?
So that's really key, and the answer to that is you want to fuse him on your sagittal view. You want to fuse him at 90 degrees, if not a touch into dorsiflexion. What I would want to avoid is fusing him in any equinus, because that can cause forefoot overload and back kneeing and sequelae such as that. On the sagittal view, I would want to basically put him square as you would with a plantar grade foot, so the heel in about 5 to 10 degrees of valgus, and make sure we don't put him into varus. That would be something I'd be trying to avoid.
Fantastic. Varus is bad. Yeah, good. All right, well done.
Great, well done. Tim, you mentioned the TARVA, so I have to just comment that the BOFAS annual meeting in Bournemouth, there was a mention to that, and I think there was a mention also that there is an opportunity for a fellowship, a TARVA fellowship. So I think, yeah, if somebody's interested, they can drop a message or so. Yeah, so well done. There are no questions for now on this one. Hang on, there's one coming in. So Parag is asking, what is the risks of problems in the future of sequela of adjacent joint arthritis with a fusion?
Well, basically, do you want to take that, Yaser?
Yeah, so, we all know after ankle fusion, you will get adjacent subtalar joint arthritis as well. But you can deal with it. How soon, it's between sort of 5 to 10 years. How soon one gets it, don't know exactly. But, you can then assess that and address them separately. But in cases, so that's why you would do a MRI scan and a CT scan to assess that, and particularly even in younger patients which are rheumatoid, the new sort of understanding is that you want to keep one joint mobile. So if they have a subtalar arthrosis and an ankle arthrosis, you will do a step. Well, I would do a stage operation, fuse their subtalar joint, and then come back and do an ankle replacement. So at least they have one mobile joint. And these patients do well with sort of ankle replacements.
Brilliant, thank you, Yaser. So I think we can go to the last and most exciting case. Which
I think we've got somebody to join us, haven't we?
Yes, we do. Sarush, are you there?
We've got a celebrity from Royal London Rotation, isn't it?
There he is.
Sarush, hi there, and well done for volunteering. I will try and be gentle, but hopefully you've seen it's been in good humor so far. So, right, let me just get it to move. Okay. Oh, are you there? Yeah, you're there. Fantastic. Okay. So, Sarush, this is a, let's say, 57-year-old, not very well controlled diabetic who has come to casualty, not feeling great, but with this appearance to his foot that he's concerned about. What would be your observations of what you're seeing in this clinical photograph, please?
So it's a clinical photograph of the right foot, forefoot, demonstrating redness, erythema, and really threatened soft tissues over the hallux in the first MTPJ. With the history of diabetes, I've been saying that this is a pointing abscess and a diabetic foot attack. So I want to take a history from this patient, establish the chronicity of his symptoms, whether he's had any trauma that's preceded this, and how his diabetes is generally controlled, whether he's got any non-orthopedic manifestations and who follows that for this, whether he's got a podiatrist already who has had any other surgery.
Okay. So basically, to answer your questions, his diabetes control is not good. He is under a podiatrist, but this has occurred in the last 48 hours. It's gone. He had a bit of he noticed something small on the top of his foot, but no penetrating injury. but it just occurred spontaneously within 48 hours. So any investigation you would get to try and look at this a bit further?
Yeah, so I would investigate initially with some blood tests, FBCs using ESR and CRP.
Yeah.
I would do some just bedside observations as well if I'm already septic.
Yep.
And I would get an X-ray of the foot in the first instance. Of course, I'd do a neurovascular examination as well, establish whether he's got sensation, whether he's got pulses, and if I can't feel them, I'd use an ultrasound Doppler to do so.
Okay. So, well, let's go through those. So on his blood tests, you would expect you've got raised inflammatory markers. You've got CRP of 200. He's got a raised white cell count, but his OBS are perfectly okay.
Right.
Why do we sometimes see that?
The diabetics don't necessarily mount a systemic inflammatory response as well as those who with better control do, I think.
Precisely, absolutely right. Absolutely right. And then on the X-ray, what kind of features would we expect to see with this abscess, as you put it?
So we may see frank features of osteomyelitis. Yep. We may see features of a diabetic arthropathy, yep. And there may be an associated trauma fracture that's been neglected.
Very good. What's your management of this patient?
So I think if the patient was septic, if we're worried about physiological stability, I would start them with broad spectrum antibiotics, having discussed them with the microbiologist. I'll take an MDT approach to this patient in general, and I would involve the podiatrist, the endocrinologist, and the diabetic foot specialist team. If I were on a weekend and on my own, I'd be quite worried about waiting for the NDT advice on this. And I think the priority is to decompress the pus and debulk any abscesses that might be there. So I'd take it to theatre. I'd do an aggressive debridement. Yep. And I think taking any dead and devitalized tissue, any inflamed tissue, and then cover it up, admit the patient to the ward and monitoring and await my colleagues in the MDT.
Good, brilliant answer. You've got it. It's get them to theatre that night, isn't it? Incise and drain, then worry about the vascular bits afterwards, because this is what's potentially going to make him very, very sick. So if it needs to be done in the middle of the night, it needs to be done. This shouldn't wait very long at all. Good answer, Suresh. Very good indeed. Okay, so a slightly different chap who hasn't got the infection in his great toe, but is a diabetic and has come in with a red hot foot. What are we seeing on this X-ray and with links to that kind of presentation?
Okay, so this is a lateral radiograph of the left foot demonstrating a frank dorsal dislocation of the talonavicular and medial cuneiform. There's a rocker bottom deformity with a plantar exostosis. My concern here is of a Charcot joint. I can't see any, a Charcot arthropathy. I can't see any callus formation. So I'd call this probably a kind of stage 1 fragmentation with acute dislocation. But I need to differentiate Charcot from infection. So the same way, taking bloods from the examination, I can elevate the leg and see if the swelling and redness and erythema improve over 30 minutes. That's traditionally said to be a differentiating feature. I'd also want to know from the history if there's any other reason for a Charcot, any neurological diagnosis, diabetes, alcohol, anything like that. Okay,
so good. So excellent. So you picked up, what do you notice with the foot? What's the key differentiator between one foot and the other that you often will see that tells you this is a Charcot and how we're going to monitor it?
So the chronicity, so it might be a more chronic picture, and there may be no pain, but everything else can mimic. So the inflammatory markers can be up.
Correct. So it's very difficult to differentiate between Charcot and infection, as you say. So basically, you mentioned here that this has got a frank dislocation, but you also mentioned this was in the fragmentary phase. What stages of does Charcot go through?
So I think Eichenholz talked about 3 stages: initial fragmentation with dislocations, and then a coalescence phase where you see a callus formation, and then a reconstruction phase where you begin to get remodeling. So if we were to manage surgically, some would argue that you should await the reconstruction phase before intervening, if at all.
Okay. So here we've got that exact thing. We've got that consolidation phase here, where we've got the rocker foot problem, and we can see it on the clinical photograph above. Talk to me, if you would, about how you've managed this non-operatively.
So non-operatively, I would go through the MDT, but ultimately I would total contact cast to allow the patient to progress through the phases and through to remodeling. The principle of this would be to distribute the forces evenly across the foot and to minimize contact stresses and protect the soft tissues.
Okay.
So
I'm sorry about this. So you're right. So the key thing about it is that the foot initially is hot, and we watch that temperature drop off as it coalesces. So that's what the podiatrists will watch in clinic as they do contact cast after contact cast after contact cast, is looking for that cooling of the foot as it coalesces. All right. So good observation. And then you mentioned about the orthotic. What's this boot on the left-hand side of your picture?
This is the Crow orthotic, so Charcot restraint orthotic walker, and this can be used after an initial period of casting. We can move to this. It's got it can distribute forces as well, and it's got a kind of one rocker sole, which again takes a lot of the force out of the midfoot, and you can use redistributive insoles as well to help with the pressure of the bony prominences in the soft tissues.
I think you're right. So the difference is these are accommodative orthoses, which are called total contact insoles, because in the diabetic neuropath, they don't respond in the same way. So you've got to spread the load evenly across the foot, rather than more traditionally, you'd focus on the forefoot and the heel and balancing it correctly, wouldn't you? So, So good. So you've got a Charcot restraint walker with a rocker bottom to help them walk, which holds everything still and stable, allowed to walk, but evenly distributing the pressure. So we try and prevent ulcer formation and breakdown. Suresh, really good.
Perfect, Suresh. Thank you for your thank you for your participation. This was very interesting. Thank you, Tim. We have one final question, and I'm not sure if we will have time for going through the rest of the topics, Tim and Yaser. Okay, so let me go with the question. So it's Donatus again. Thank you for participating. He asks, in acute diabetic foot abscess, does differentiating between necrotizing fasciitis and diabetic foot abscess matter?
Good question, because that can at times be difficult. And clearly, I suppose to answer the question specifically, yes, it does, because necrotizing fasciitis, you have to be far more radical. I don't know about you, Yaz, I've never seen it present. Well, that's not true. I have seen it in diabetics, but there'll usually be a big abscess if there's a soft tissue collection, and you'll see that pointing, whereas necrotizing fasciitis is that more cellulitis, then necrosis, and then spreading up the more proximally away from the central point. So in the end, you're going to make your incision and drainage and see what you find. And if you find worrying signs of necrotizing fasciitis, such as that dishwater fluid or the planes coming apart, you will have to do more aggressive debridement, and then watch the wound afterwards. And you're always going to go back and look at it hours later, the next day on the ward, and you're going to monitor your patient. But yes, if you got concern from the any microbiology, this was a necrotizing fasciitis, you'd be even more aggressive again.
Yeah, I mean, as I said, a neck fash. I don't know. I mean, how much you have guys dealt with, but there is a distinct smell as well of neck fash, and you can sort of smell it in the theatre corridor when you're doing your debridement. So but I guess you look at the patient, do your learning scoring, look at the lactate, look at the urea, all of those, sort of get the score right. And, you know, if the skin looks dead, then you take it off, you know, you don't leave that. You can do your finger sweep fat, you know, if this is the sign. So all of those, you can try and help you out, but it can be difficult, but you ask for help.
Perfect. Thank you. Thanks.
Okay. Well, look, that's been an hour, hasn't it? I think.
Yeah.
If there's any further questions, do ask. Were there any hands? Any other hands up? May, or did most people?
Yeah, there was hands up. So Villa Setker, but that was at the right beginning, so I'm not quite sure.
Okay.
Would you like me to?
Do you want to see if he wants to? Do you want to just upgrade him and see if he's up for it?
Yeah.
Yes, I'm here.
Thank
you.
Yeah.
Oh, hi there, Vilas.
Hi.
Okay. In which case, people, if you want to leave now, it's been an hour. You're more than welcome. But why don't we do one more then?
Yeah.
You're more than welcome to put your video on if you want, or stay behind, or stay hidden if you wish.
Yeah, I can't put my video on. I know what's the reason for that.
Don't worry. Can you see the screen? Okay.
Yes, I can see the screen. Yeah.
Okay. So here's a good one. So, what is being demonstrated in this video?
Okay. So this is a.
You're muted, Vilas.
Yeah, I think I can. Fine.
There we go.
So this is a video wherein they are demonstrating the Thomas or the Simmons test to check for the integrity of the tendo Achilles tendon. In this particular test, as you put pressure over the cuff, automatically, if the tendo Achilles is intact, the patient should be able to plant a flex on its own, and this is what is being demonstrated.
Good answer. I wouldn't use the word pressure. It's a squeeze and lift test. All right. And then, as you say, you will see passive movement of the foot. Okay. And what would you see if looking at the resting picture there? If there was an Achilles tendon rupture, what would you see different in the resting posture of the foot?
So there's a Matlis test, Matlis angle of dangle test, which shows that if the tendo Achilles is ruptured, then patient would have more plantar flexion.
Okay, so you can imagine where this question would go in an exam.
Yes.
So basically, this patient has presented to you, you've done Simmons tests, and they've got a rupture. What points in the history are important to help discern your management?
So in the history, I want to know the time durations when this has happened, patient's occupation, patient's career, and patient's sporting aspiration. I also want to know whether the patient is diabetic or a smoker, and what are the patient's expectations out of the treatment. I also want to know whether there is any inflammatory pathology present.
Brilliant. A distinction answer. That is a really good answer. The only other one I could think of would be about the medication. Are you aware of any medication that can predispose people to Achilles ruptures?
Yes, it can be because of steroids, or it can also be because of the fluoroquinolone kind of antibiotics.
Well done. Okay, so let's say all those bits are good. The one thing what you mentioned at the very beginning was, when did they do it? So this rupture happened today. All right, so she came straight from the football pitch and straight to casualty, and it's about 6 hours since she did it. She is 35 years old, otherwise fit and healthy, and does enjoy playing badminton and sport, but only at amateur level. So what would be your management option thoughts?
So I'm going to give this patient options here. My initial thoughts is, one, I want to see, I know my diagnosis has been established, but to see my treatment protocol, I like to get an ultrasound with leg in full plantar flexion to see if the gap between the tendon is less than 10 millimeters, which if it is less than 10 millimeters, I'll be able to give the option of functional rehabilitation to this particular patient, depending on the protocol as established in my trust.
Okay, well, so let's run through that. So you've done an ultrasound. I think that's very fair. Do you have any evidence, or are you aware of any of why we do that ultrasound? Any papers in the background at all?
So there has been studied the SMART studies by Hutchinson from Belfast, and there has been another study from Swansea. I think it's the Wallace study, which is Wallace was a study of 945 patients, and Hutchinson was a study of 245 patients. Hutchinson showed 1.1% re-rupture rate, and Wallace showed 2.3% rupture rate in 945 patients.
Very good. That's a very good answer. All right. So this lady has an ultrasound scan in equinus, and it is less than 1 centimeter. So you mentioned that you've got options of non-operative and operative clearly, and then mentioned about functional rehabilitation. What is functional rehabilitation?
So functional rehabilitation is you let the patient weight bear, and you do that depending on the anatomy of tendon healing principles. So you get the tendon healing principles in there, and you ask the patient to be in a plaster for a week initially because of the stage of inflammation, and then you give the patient something called a Vacoped boot and not a normal walker boot, and allow the gradual range of motion of the ankle over the period of 12 weeks. And you monitor this with the help of the physiotherapist, and as well as sometimes you might have to do an ultrasound at the end of your protocol.
Okay, so good. So I think again in the exam, the Vacoped boot is good because of range of motion, but there is some evidence to support the air cast boot with wedges under the heel. I think the key principles you'd want to bring out are the fact that you are walking and weight bearing on a protected equinus angle, that you gradually decrease to plantigrade as time goes by, and you could do that with some motion potentially, but it is the loading of it and functioning as you go that is differentiating from what used to be with the cast immobilization. Okay, how are we doing for time, May? Are we all right?
Yeah, I think you can finish with this case. If you want, there are other hands raised if you want to take other cases.
Okay. Well, let's okay. Well, which case, if you want to pop up somebody else, we could just bring somebody else in.
Thank you, Vivas.
Sure.
Yeah. Thank you.
Vivas, we'll carry on while May's doing it. So surgical approach. Are you what surgical approach? If she wanted surgery for sport aspiration reasons, etc., she wanted surgery, what would be your surgical approach and mechanism of repair?
So surgical approach would be by using a posterior medial approach, more vertical in the longitudinal incision, and I'm going to expose the peritoneum and then debride the edges, and then do it by modified Kessler's technique of sutures to put it back in place.
Okay. Any principles of that repair technique that are important or proven? The main one is you should have a 4-strand or 4-core suture repair for optimum strength. So your Kessler I like, but you want 4 strands, and you always repair the peritoneum at the end because that can add some extra strength to it. All right.
Okay.
I think we need to move on. Vilas, that was very good and actually added to this lecture, mate. Really grateful. Thank you very much indeed.
Brilliant.
Thank you.
Thank you. We have Kanish. Kanish next. Kanish, can you hear us?
Yeah.
Yeah, we can't see you. Is that on purpose or no? Okay, fine.
Yaser, do you want to take this one?
Yeah.
So thanks for volunteering. Okay, tell me, what do you see here in this clinical picture? What's going through your hand?
So that's a clinical photograph of the plantar aspect of the right foot. There is some plantar ecchymosis under the arch. So I'd be suspicious that there's potentially a history of trauma. The patient's also in bed and it has a dressing on slightly proximally up the leg. This, to me, the first thing that would be going through my mind is, has this patient had any trauma, particularly concerning a Lisfranc injury? That would be the first thing that would be going through my mind. So I'd get a history from this patient. I'd want to know if they've had any serious trauma to the foot.
Yeah.
How long, if there was a history of trauma, how long that's been going on.
Yeah.
the soft tissues of the foot, and whether or not the foot is deformed. I would complete my examination by feeling for the pulses and checking that sensation is present, and making note of whether or not the general aspect of the foot has skin creases, or is it unable to wrinkle it or not.
Okay, so this patient did have trauma. There was a hyperplantar flexion injury. As you rightly said, it's Lisfranc injuries going through your head, so you would assess this patient stuff. Tell me a bit more about Lisfranc injury. What is it?
So a Lisfranc injury is an injury to the Lisfranc ligament and potentially disruption of the entire midfoot. The classic presentation is a forced axial force onto a plantar flexed foot that can result potentially in a dorsal dislocation, although the dislocation can go either medially or result in a complete dislocation of the midfoot. There's disruption of the Lisfranc ligament, which is also consists of the plantar and the dorsal ligaments, and there are intermetatarsal ligaments as well that may be disrupted. The disruption can be either entirely based on the medial column, or it can be a lateral column injury. With respect to a Lisfranc ligament, the most important column is the middle column. And when we are talking about reconstructing Lisfranc ligaments or treating them surgically, the principles we talk about are restoring the keystone, which would be restoring the articulation between the second metatarsal and the middle cuneiform. Looking at this radiograph, it's an AP radiograph of the left foot, which is weight bearing. Mm-hmm. There are some worrying features. So the medial border of the medial border of the second metatarsal does not completely line up with the medial border of the middle cuneiform. Yeah. There's also within the first web space there's suspicious. It's slightly suspicious of a flex sign. So I'd want to get a complete foot series, including a lateral X-ray, where I'd be looking for elevation of or dislocation of the second metatarsal, which would be consistent with a Lisfranc injury. And on the oblique, I'd be looking for whether or not the medial border of the fourth metatarsal lines up with the cuboid, again indicating possible injury to the lateral column.
Okay, excellent. So what's the importance, as you said, look, medial column, lateral column, what's the importance of the Lisfranc ligament? Where is the Lisfranc ligament running from?
The Lisfranc ligament runs, it's got three components, a plantar, middle, and a dorsal component. It runs from the middle cuneiform to the base of the medial cuneiform to the base of the second metatarsal.
Okay, so what's the significance of that?
So the Lisfranc ligament maintains the arch of the foot, and if that ligament is disrupted, then there is a disruption of that of the joint between the second metatarsal and the middle cuneiform. Left untreated, it can lead to a collapse of the arch and progressive midfoot arthrosis.
Okay, excellent. So that's the strongest ligament connecting the medial to the second ray, right? There is no intermetatarsal between those two. So if that goes, then everything sort of shifts. Now, you said rightly that you will look at the lateral radiographs as well, subluxation. Why do you get dorsal subluxation?
So the dorsal ligaments are weaker than the plantar ligaments. So the plantar ligaments stay intact and the dorsal ligaments fail, and therefore the metatarsal subluxes dorsally.
Fantastic. Okay. So this patient present to you in an A&E. You've done an ATLS assessment on this patient. What's your management option?
So I'd want to know a bit more about the patient. I'd want to know where if they had any past. So I guess on the history, is it acute or chronic? How the injury has occurred and whether or not it's associated with any other injuries. I'd want to know if they had any past medical history that might complicate an anaesthetic, particularly diabetes. I'd want to know if they were a smoker or a non-smoker. And then going on to the social history, I'd want to know how much they ambulated, if they had any particular sporting hobbies, for instance, if they were a marathon runner or very active. And then if they were on any particular medications that might complicate an anaesthetic.
So they're fit and well. They're 32 years of age, fit and well, does a manual job. And how would you manage this patient?
So in a fit and well 32-year-old, I would manage this injury operatively. I'd want to get a bit more imaging. So I've already asked for the 2 views. I'd also get a CT scan.
Mm-hmm.
With respect to Lisfranc ligament injuries, they can either be purely ligamentous or they can be bony, which has an implication on how they are managed.
Mm-hmm.
So I'd get a CT scan to assess that. For the purely ligamentous injuries, I'd tell the patient it's got a poorer prognosis in respect of outcome. And for that injury, I'd recommend a primary arthrodesis. If the fracture pattern on the CT scan, if there was associated fracture on the CT scan, then I would aim to fix it with bridge plating.
Okay, so tell me about your aims or principles of fixation. What are you trying to achieve here?
Appropriately marked and consented patient taken to theatre. My personal setup would be to do this supine and to bend the operative knee up to look at the AP radiograph. The principle, the most important thing is to restore the articulation between the second metatarsal and the middle cuneiform, which is called the keystone. Quite often these injuries, once the keystone is restored, the rest of the middle and the lateral columns often reduce themselves. However, I'd still stress the third, fourth, and fifth tarsometatarsal articulations with using the piano key test. I would also assess the middle column to ensure that that was stable. But I would start off by restoring the keystone and then assessing which of the columns are unstable. Depending on if there are fractures associated.
All right, what about the first TMTJ?
So again, I would look for the border between the medial cuneiform and the first metatarsal. I'd also piano key that to see if there was any evidence of instability. And essentially, if there was, then I would again bridge plate across that. But the first thing I would start by restoring the second tarsometatarsal articulation.
Excellent.
Thank you, Kanishk. Thanks. Yes, sir. Sorry, I think we might be running out of time.
Yeah.
So
Okay.
thanks, Kanishk.
Thank you very much.
Yeah, we have one final hand raise. So we're 15 minutes.
I think
a little bit more than 15 minutes over our time. So Tim and Yaser, would you like to take one more? Nabil has been.
Okay, we could do one more brief one. I think we could manage that.
Yeah.
And then we'll probably call it a night there, I think. So if you want to call up
right.
Nabil.
Okay, thank you, Kanishk.
Just while we're getting through it, if you open up Nabil, everybody just do look in the chat function, because that's where you'll get the feedback code. There'll be a QR code later on, but the feedback code is FAB4T52. And it's in the chat function, and that way you can get your Royal College of Surgeons certificates and bits and pieces. All right.
Just on the last topic, the Lisfranc, which the arthrodesis versus fixation, I think the most quoted paper, there was a journal club as well, BOFAS. You can access it on the BOFAS website, but it's about the Coetzee arthrodesis versus fixation. Do read that paper. That's the most quoted. There are pros and cons about it, so you need to understand what they used and what they compared with.
We still got Nabil, or is he gone? Are you there, Nabil? Who's coming for this last question?
I think he's probably gone.
Has he gone?
Yeah, not there anymore.
Have you gone, Nabil? If you want to come back, you're very welcome. I think we might have lost you, in which case we'll probably call it a day.
Yeah. I think let's.
Okay, right. I think on that basis, then I think we will call it a night. And realistically, hopefully you've enjoyed that run through there of examples of Vivas. It's been quite entertaining, I must admit. What did you think, Yaser? Did you? It's rather interesting being on the other side of the fence again, isn't it? After all this time. But it also just leaves me to pass on a few thank yous, because this is the last in our Lecture of Distinction series. Do remember they are all available on the BOFAS YouTube channel. So if you just Google BOFAS YouTube, then please, they're all there recorded. We're going to look at this one and just check we're happy with it. So it probably will go up, but we'll see about this one. I've just seen about the codes. The code is in the chat function. It's, if you want to write it down, it's FAB4T52, and it's just been put in the chat function again. A couple of questions about that, and I see Nabil, you've typed a question. If you haven't got access, I think we'll leave it for now. I'm just going to take 2 minutes just to thank people who've been involved in this series. As I said, there's been 51 of them, and we've been absolutely screwed without this IT committee, who've been brilliant throughout, led by Robert Clayton and the team, including a number of fellows. And in the future, if you guys want to get involved, stay in touch with BOFAS, because there's lots of projects going on. A true backer, as always, is Jo Millard, and a big thanks goes to her. But I think you guys really need to bear credit to Yaser Ghani, because it was Yaser 2 years ago who came to BOFAS and said, look, this is going bad. There's no educational stuff going on. We're going to need something. There's going to have to, otherwise we're really going to be in difficulty. What about this as an idea? And from that, this grew, and it grew and grew. And as you know, we've now got, 51 letters is an astonishing number. And we've had so many speakers, so many moderators involved. So big thanks, but also particularly to Yaser Ghani. So well done, mate. All right.
Thank you very much. Look, I think, this has been great. As I said, there is a lot of people behind the scenes, fellows, IT committee, Robert, Curran, Matt, Shalane, Joe, you, Tim, who've been extremely supportive, Rick, Brown, who was the education committee president as well, and now Callum, Clark. So it's been a joint effort. These are all, thanks to all the speakers and moderators. This is all free of charge. They've all given up their time for this. This is all available still online on the BOFAS YouTube and the BOFAS website. So I hope that this is a useful tool for you guys, not just for FRCS, but for everyday sort of use. And I hope you guys have found it useful. I mean, the feedback has been incredible, and that's what, that's why we've continued this. But I think now is the time to finish it on a high.
Grand. Well, it's good night from me.
Good night.
Good night.
Take care.
Thanks, mate.
Good night. Thank you.